Hi everyone, my name is Naoka Murakami. I'm a transplant nephrologist and assistant professor of medicine at WashU in St. Louis. I'm going to talk about the use of immune checkpoint blockade in kidney transplant recipients. Okay, this is my bio. I did a nephrology fellowship at Brigham Young MGH, and I'm currently at the WashU in St. Louis with my clinical focus on cancer in kidney transplant recipients and the roles of immunotherapy, associated acute kidney injury, and acute rejection. So I have some disclosure here. And today we're going to learn together the increased risk of cancer in kidney transplant recipients and evidence-based prevention and treatment options for cancers in kidney transplant recipients, and also think through the risk and benefit of novel cancer-targeted therapies in transplant recipients. So we'll start with a case, a 66-year-old man with a history of ADPKD and living-related kidney transplant 16 years ago. He presented with multiple skin lesions, and biopsy of skin lesions revealed invasive cutaneous squamous cell carcinoma. He likes gardening and often goes to outdoor activities, so lots of sun exposure. His immunosuppression regimen includes mycophenolic acid 180 milligram twice a day, tacrolimus 4 milligram twice a day with trough level of 6 nanogram per ml. Other medications include hydrochlorothiazides for high blood pressure. Laboratory values looks good, creatinine of 0.9, urine protein creatinine ratio of 0.2 gram per gram, electrolytes and liver functions are normal, CBCs are normal as well. So the question is, what is the management that helps the patient prevent the non-melanoma skin cancer? Except A, switch mycophenolic acid to azathioprine, B, switch tacrolimus to sirolimus or everolimus, which are mTOR blockade, C, discontinue hydrochlorothiazide, D, annual full body skin exam by dermatologist, or E, recommend sunscreen use at outdoor activities. So the answer is A, switching mycophenolic acid to azathioprine wouldn't help prevent non-melanoma skin cancer, and we will look together why. So cancer is a major cause of death after kidney transplantation. These are the two graphs showing the cause of death in dialysis population on the left and transplant population on the right. As you can see here, cardiovascular cause of death is 50% in the case in dialysis population. However, in transplant population, of course, cardiovascular is the biggest cause of death, but followed by infection and cancer. And then after a few years since the publication, the cancer becomes the second leading cause of death in transplant population. So that's a big issue in a kidney transplant recipient. However, the death due to cancer didn't decline over a couple of decades, which is unfortunate. This is a graph showing the 10-year cause-specific mortality hazard ratio with a reference year of 1996. As you can see here, cardiovascular cause of death and infectious cause of death decline over the past 2 decades. Cancer associated death increased for the past few years, and we should do better on preventing and treating them. So this is a graph showing the standard incidence ratio of various types of cancer, and in comparing the pre-dialysis CKD patients and then patients on dialysis on orange, and then post-transplant patients in gray. As you can see here, cancer incidence is higher after transplant. If you can look at Kaposi sarcoma, for example, the incidence of cancer is 10 times higher in pre-dialysis CKD patients, and then higher in dialysis patients, and much higher, tenfold higher in a transplant population. As you can see through the risk shown in gray, post-transplant patients are the highest risk of sarcoma or non-melanoma skin cancer or non-Hodgkin lymphoma or kidney cancers. So these are very important things to keep in mind when treating or caring for transplant recipients. However, breast or prostate cancer are at the similar level of a general population or dialysis population. So the risk of cancer is very much the cancer species dependent. So how do we screen cancers post-transplant. So this is the primarily from KDIGO guideline published in 2009. And then there's some updated guidelines from AJT or American Transplant Society, as well as Canadian Society of Transplantation. But through all those guidelines, we recommend screening skin cancer with a total body skin exam by specialists, especially dermatologists, every year. So that's a universal recommendation for kidney transplant recipients. For other solid organ cancers, we followed the general population guidelines by USPSTF, for example, pap smear for cervical cancer, mammogram for prostate cancer, or FOBT colonoscopy for prostate cancer as an age-appropriate cancer screening. Other cancer screenings like prostate cancer, lung cancer, liver cancer, kidney cancers are not recommended or not enough evidence to recommend solid guidance. So next, moving on to some moderate or changeable risk of the cancer. So azathioprine is one of the immunosuppression drug that is associated with an increased risk of squamous cell carcinoma, SCC. It's been reported that relative risk of squamous cell carcinoma of the skin is 1.56 on those who are on azathioprine compared to those who are not on azathioprine regimen in the kidney transplant recipient. And in addition to kidney transplant recipients, even in patients who with the autoimmune disease had a higher risk of non-melanoma skin cancer by 3 to 5 times when they're on a azathioprine-based regimen in inflammatory bowel disease, for example. What are the underlying mechanisms that azathioprine accelerates the progression of the skin cancer? So you can see on the right-hand side, this is the scheme showing the progression of normal skin to precancerous region of actinic keratosis to invasive cutaneous squamous cell. So azathioprine can inhibit the DNA repair system. As you can see here, the normal skin can get UV radiation and get DNA damage, which needs to be repaired. But azathioprine inhibit that repair system, thereby accelerating the precancerous lesion to become invasive cutaneous squamous cells. And switching from azathioprine to non-azathioprine regimen, especially mycophenolate mofetil, reported to help reduce the risk of squamous carcinoma with a hazard ratio of 0.24. So switching back from mycophenolate to azathioprine would not help preventing or treating cutaneous squamous cell carcinoma in the question. How about other medications? Hydrochlorothiazide is associated with an increased risk of non-melanoma skin cancer. Post-marketing studies suggested a small increased risk of cutaneous squamous cell with hydrochlorothiazide use, with an odds ratio of 2.0 to 3.3, higher in the long-term use. And another cohort study suggested even higher odds ratio of 4.0 in 80,000 cases versus 16 million healthy controls. Based on that assessment, FDA package insert now has a warning on the cutaneous squamous cell risk. However, the absolute risk is small, increased by 1 case per 16,000 patients per year. So based on those evidence, we do recommend use of sunscreen greater than SPF 30, which provides the protection for both UVA and UVB, and we recommend them for all transplant recipients. So what about other immunosuppression regimen? Conversion to mammalian target, the rapamycin mTOR inhibitor, is known to be associated with a low risk of skin cancer recurrence. So this is a well-performed tumor rapa study. This is a randomized controls study to look at the risk of recurrent cutaneous squamous cell carcinoma. As you can see here, one group remained on calcineurin inhibitor, which is primarily the cyclosporin at the time, and another group was converted to sirolimus, which is mTOR blockade. As you can see here, cancer-free time was much longer in sirolimus group, thereby showing the benefit of sirolimus conversion from calcineurin inhibitor to prevent the secondary squamous cell carcinoma in this group. However, we need to be very, very careful when we're switching from calcineurin inhibitor to mTOR inhibitor. The benefit of non-melanoma skin cancer prevention is repeatedly shown in multiple cohort studies. As you can see here, this is another cohort study published a few years later showing benefit of preventing secondary non-melanoma skin cancer in mTOR group shown in dotted line compared to non-mTOR group in solid line. However, if you look at other solid organ cancer other than non-melanoma skin cancer, these benefits went away. And another meta-analysis suggested that switching from calcineurin inhibitor to mTOR blockade may increase the risk of cardiovascular events and even death. So we need to really weigh the benefit and risk of switching calcineurin inhibitor to mTOR blockade in the patients with a skin cancer. So moving on to the second part of novel cancer therapy. Case number 2. 58-year-old woman with a history of living kidney transplant 24 years ago for reflux uropathy. She was recently diagnosed and started treatment for metastatic melanoma. She presented to clinic with a decreased urine output and hematuria. Her immunosuppression include prednisone 5 milligram only, and other immunosuppression was discontinued at the time of the immunotherapy initiation. Other medications include carvedilol for high blood pressure and omeprazole for acid reflux, and she was started on combination of ipilimumab anti-CTLA-4 and nivolumab anti-PD-1 3 weeks ago. Blood tests include elevated creatinine of 3.4 from her baseline 1.2, and urine protein creatinine is elevated 1.0 gram per gram, and the urinalysis was pretty active with 1 plus protein, 1 plus blood, and 2 plus leukocyte X-rays. And sediment showed numerous red blood cells and white cells, as well as some white cell cast in the low power field. And kidney biopsies performed due to the AKI. So the question is, what is the most likely kidney lesion that would be seen in this patient? A, acute cellular rejection. B, BK nephropathy. C, IgA nephropathy. D, de novo membranous nephropathy. E, metastasis of melanoma to the allograft. So the correct answer is A, acute cellular rejection. So immune checkpoint inhibitor has been widely now used and part of the standard of care for many cancers. And it works by unleashing the brake against cancer immunity. This is the cartoon showing the interaction between the T cell in the center with the antigen-presenting cell on the left and the tumor cell on the right. In order for the T cells to be fully activated, they require 2 key signals. First signal being the interaction between T cell receptor on the T cell and peptide MHC on the antigen-presenting cell. The second signal being the interaction between co-stimulatory receptor CD28 on the T cell and CD8086 on the antigen-presenting cells. However, if the T cells express co-inhibitory receptor such as CTLA-4 or PD-1, or if the tumor cells express PD-L1 co-inhibitory receptor, these T cells cannot be fully activated to elicit anti-tumor response. The idea of the immune checkpoint blockade is by blocking antibody against co-inhibitory receptor CTLA-4, such as ipilimumab or nivolumab, pembrolizumab, cemiplimab, which are anti-PD-1, or anti-PD-L1, such as atezolizumab, avelumab, or durvalumab. Thereby, T cells can be fully activated and kill the tumor cells. So immunotherapy has been, very effective in treating cancer. However, it does come with a cost. So we've learned for the past 5-10 years that immunotherapy can cause immune-related adverse event, IRAE, in different or various organs on the body. As you can see here on the left-hand side, this is a distribution of IRA. It can literally affect every single organ. Skin rash being most common, but the immunotherapy can affect the GI tract like colitis or hepatitis, and it can be very severe and causing pneumonitis or myocarditis, which can be sometimes fatal. Of course, as a transplant nephrologist, we need to be worried about acute kidney injury due to interstitial nephritis or resection. And it's also important to know that these side effect comes in a different tempo. Skin rash comes in the very early phase, 2 to 4 weeks after initiation of the therapy, followed by GI colitis, 6 to 8 weeks. And our renal side effects manifest a little bit in the later side, 14 to 16 weeks after initiation of the therapy, that we can use as a hint when diagnosing those side effects. So acute tubular interstitial nephritis is the most common kidney IRA. This is a classic case of immune checkpoint blockade associated acute kidney injury biopsy. As you can see here in the PAS staining, there are massive infiltration of immune cells, and if you do immunostaining, you can see both CD4s and 8s, and those cells are expressing cytotoxic cytokines such as granzyme B or perforin, and some of them are T regulatory cells expressing FOXP3. So let's step back and look at the epidemiology of immune checkpoint blockade associated AKI in non-transplant patients first. So all AKI from single center studies reported 16 to 17% of the patients treated with immune checkpoint blockade had acute kidney injury, and of which truly checkpoint blockade associated AKI could be 2 to 5% from the all comers. And if you look at the different kinds of immune checkpoint blockade, CTLA-4, PD-1, combined therapy, or PD-L1 use was associated with a less frequent acute kidney injury in our population, which needs to be tested in a larger clinical cohort. So what are the clinical characteristics of ICI-AKI? Multicenter retrospective cohort study from 26 institutions, including 138 AKI cases with 276 control cases, suggested that AKI onset is median 14 weeks from ICI initiation. And this is a distribution curve. The AKI can happen pretty early, 1 to 5 weeks after initiation of the therapy, but it can happen pretty, later time point as well. And the AKI can be severe. Stage 2 AKI happen in 43%, and stage 3 AKI happen 57%, and 9% of the patient were RT dialysis dependent. What are the risk factors of ICI-AKI? From the cohort study, we learned that lower eGFR at the time of the initiation and PPI use such as omeprazole, esomeprazole, and then also combination checkpoint blockade therapy such as combination of ipilimumab, nivolumab are at the risk factor of the ICI-AKI, as you can see here in the forest plot here. And then also, patients with ICI-AKI had other organ IRA involvement as well. As you can see here in the graph, they tend to have rash, colitis, hepatitis, in addition to renal AKI manifestation. So we can use extrarenal manifestation as a hint to diagnose those ICI-AKI. So let's switch the gear to the immune checkpoint blockade used in kidney transplant recipients. Its use in the kidney transplant recipient is much more challenging compared to non-transplant population because in addition to thinking about immune checkpoint blockade and its tumor response, we need to think about immunosuppression management and allograft rejection risk. So immune checkpoint inhibitor in kidney transplant recipient, we need to think about both safety and efficacy. And for the past 12 years, we learned quite a bit. So initially, Evan Lipson's group and Johns Hopkins reported that ipilimumab anti-CTLA-4 didn't cause any rejection in a kidney transplant recipient, but the same group 2 years later reported that nivolumab anti-PD-1 caused acute rejection in kidney transplant patients. So since those are the case reports, there have been pooled case series and meta-analysis, and the rate of acute rejection was suggested to be 30 to 40%, but association between rejection episode and overall survival of the patient was unclear. In terms of the efficacy, no study has tested the clinical efficacy of immune checkpoint blockade in kidney transplant population. So we set out to conduct a multi-center cohort study with 23 institutions, and we collected 69 kidney transplant recipients to estimate the risk of rejection. We estimated the risk of rejection as 42%, and time from ICI initiation to rejection was median 24 days. So this is much faster compared to non-transplant population, which is remarkable. And once the rejection happened and had biopsy, both T-cell mediated rejection and mixed TCMR and ABMR antibody mediated rejection are common. And it can be severe, and once rejection happens, 65.5% of the patient lost the allograft and need to go back to dialysis. And we also conducted a risk analysis and found that being on mTOR inhibitors such as sirolimus or everolimus are associated with a lower risk of acute rejection with an odds ratio of 0.26. So we could potentially prevent acute rejection by using mTOR inhibitor. In terms of the outcomes, we analyzed the overall survival in cutaneous squamous cell carcinoma subgroup and found that in checkpoint blockade treated group shown in blue had a little bit longer overall survival compared to historical cohort who were not treated with the immune checkpoint blockade. So based on these results, we can probably say, despite the very high risk of acute rejection, we might be doing better job in controlling tumor response by immune checkpoint blockade. And next question is, can we mitigate the rejection, and if so, how? So this is the seminal case report published by New York group, Dr. Barnett et al., who reported a kidney transplant recipient with esophageal cancer who were treated with the immune checkpoint blockade with increased drug regimen of higher dose of prednisone with a combination with sirolimus. So they started at prednisone 40 milligram, reduced to 20 and 10. At the same time, converted the calcineurin inhibitor to sirolimus. By using this regimen, the group was able to mitigate the acute rejection, at the same time was able to manage the cancer successfully. So encouraged by this case report, we conducted a contract study, which is included kidney transplant recipient receiving an immunotherapy. But before going there, I'd like to introduce a couple of other studies that preceded our study. So the first prospective cohort study was reported from Australia group, including 17 kidney transplant recipients with any cancer treated with a nivolumab. They didn't standardize the immunosuppression, but they kept the same dose of immunosuppression regimen as they started in the immunotherapy. So they reported 12% rejection risk, and the overall response rate of tumor was 53%. And this study was followed by 2 U.S. studies. The first one was tacrolimus and ICI study, which included 8 kidney transplant recipients with skin cancer, any kind of skin cancers, including melanoma, cutaneous squamous, basal cell, Merkel cell, treated with a nivolumab plus minus ipilimumab. They used the tacrolimus and prednisone combination and saw 25% rejection risk and the objective response rate of 33%. So this was higher risk of rejection with the lower cancer control So that was a little bit discouraging. In our clinical trial of a contract study, we included kidney transplant recipients, 12 of them, with the advanced cutaneous squamous treated with a semipilimab, which is anti-PD-1 therapy. We used the mTOR inhibitor 4 to 6 nanogram per ml with a higher dose of steroid as suggested by New England Journal case report. By using this specific regimen, we were able to prevent acute rejection. None of them had rejection, and we achieved the reasonable objective response in the cancer control. So right now, one clinical trial is ongoing to test this mTOR inhibitor, then prednisone, in kidney transplant recipient, and then result to be posted soon. And in addition to our small cohort study, we conducted a patient-level meta-analysis of 343 solid organ transplant recipients who were treated with an immune checkpoint blockade, of which 243 kidney transplant recipients. As you can see here, overall survival by cancer types, the patients with a cutaneous squamous cell, the overall survival was longer compared to other solid cancer or melanoma. The progression survival was the same. The patients with a cutaneous squamous cell carcinoma did better compared to melanoma or other solid organ cancers. In this patient-level meta-analysis, we confirmed the benefit of combination mTOR inhibitor and higher dose steroids. As you can see here on the left, the rejection risk was much lower in the patient who were on combination mTOR and steroids, and the graft loss risk was also lower in the combination of mTOR inhibitor and then steroids group. So these are encouraging, and this could be potentially translatable to other group of patients who are treated with the immune checkpoint blockade. So going back to the case, the allograft biopsy showed massive infiltration of immune cells. Like you can see in the interstitium, a lot of blue inflammatory cells coming in. If you look at the higher power, we see focal tubulitis and some neutrophil cast and eosinophil infiltrate. So this is acute cellular rejection caused by immune checkpoint blockade. So just to highlight the clinical characteristics of non-transplant patients and kidney transplant recipients treated with ICI. So kidney transplant recipients suffer from higher risk of immune checkpoint blockade associated AKI or rejection, 30 to 40%. It comes in much faster pace, 24 days compared to 14 weeks in non-transplant recipients. Histology of kidney biopsy looks pretty similar, highlighted by mononuclear cell infiltrates, mixed T-cell mediated and antibody mediated rejection. The steroid response is pretty distinct. In kidney transplant recipient, they're steroid refractory and 60 to 70% need to go back to dialysis. But in transplant recipients, non-transplant patients, they are usually steroid responsive, and the requirement for the renal replacement therapy is much lower. With that, I like to summarize. Number one, kidney transplant recipients have a higher risk of developing cancer after treatment. And number two, reduction and change of immunosuppression regimen can prevent and treat cancers. Number three, novel cancer-targeted therapies such as immune checkpoint inhibitor may be associated with the risk of acute rejection, and thereby we need to focus on patient-centered decision-making before initiating the therapy. So these are our reference, and if you have any questions, please do feel free to reach out to my email. I'm happy to answer any questions. Thank you.